So good morning, or rather good afternoon, everyone. And thanks, Dr. Sharkar, for those extremely kind words. Now I'm going to talk on the current role and future perspectives of artificial intelligence in echocardiography. And these are my disclosures. I'm not an expert on artificial intelligence. I never would have chosen this topic if I had other options. And I have not used artificial intelligence to create this talk. But to be honest, I must admit I tried ChatGPT, but the result wasn't satisfactory. So what is artificial intelligence? And I Googled to find a definition. And this is what I found. It is the ability of a machine to perceive its environment and perform measured actions to maximize its chance of success for a specified goal. Wonderful, isn't it? I like this definition very much. Only that I was unable to grasp the meaning. So I thought of digging a bit deeper, and this is what I found. These are two pictures. If you ask the machine or artificial intelligence to recreate the second picture along the lines of the first picture, then this is what you get. Amazing. This is artificial intelligence? Well, it's not as simple as this. It's a bit more complicated, but we'll come to that in a minute. Now, under the gamut of artificial intelligence are two terms that we must know. One is machine learning, and the other is deep learning. So what is machine learning? Now, in our medical schools, we were taught to recognize patterns in the ECG, echo, chest x-rays, and we learned and passed our examination. This was machine learning. So what you do in reality, you feed the machine or the computer with a lot of data, and they learn from it, and then later they would be able to independently interpret that data. And that's machine learning. So what is deep learning? Now imagine you have passed your graduation, post-graduation, and now you are a consultant with years of experience behind you. And now you're faced with a data or maybe an image which you have never seen before. So you do not have much knowledge about it. But still, with your knowledge, experience, memory, your IQ, you are able to decipher that data. So this is deep learning. What the computer does, it starts thinking like a human. It has developed a brain, which it actually walks through multiple layers of artificial neurons. And using its memory and experience, the computer is able to say certain things which otherwise they wouldn't have been able to say. And at times, this brain of the computer could be even better than that of human, probably most of the time. And they're also able to think very fast. So that's deep learning. Now, to give you an example, so a machine is actually fed with a number of pictures of dogs. And later, you have been shown this particular picture. Well, the machine is able to say, well, this is a dog. And then you feed this machine with a lot of pictures of penguin. And you show a different picture of penguin. And it's able to say, well, this is a penguin. But what if you provide this machine, ask this machine, what is this picture? Is it a dog or penguin? Well, the machine, with machine learning only, may not be able to say that. But here is where deep learning comes in. It would say that, well, it's actually a picture of a dog which is dressed like a penguin. So this is deep learning. Now, let's just switch gears and come to some of the current limitations of echocardiography. For good acquisition of image, we need good training. But there is shortage of trained staff. And why is it? Maybe that we are not good in training. Maybe that sonographers are not interested in their training. But then, in reality, we have shortage of trained staff. But again, we know that the interpretation is subjective and depends on the expertise of the staff. If you do not have trained staff, then the interpretation may not be accurate. Now, Again, there is limitation of human eyes and mind to register all the moving data, say in a video clip of an echo clip. For example, any of you have seen the latest James Bond movie? Well, I don't know the name, but say you have seen a James Bond. Oh yeah, someone put their hands up. What's the name of the movie? No? Okay. So imagine you all have watched the movie, and then I ask you, tell me how many shots were fired in a particular scene. Will you be able to remember? Did you even register how many shots were fired? No. So similarly, all we see in an echo at the same time, we may not be able to register everything. That's the limitation. Now, many data that we need in echo is time consuming to gather, difficult to manage time in a busy lab. Now, you remember in late 1990s, there was a survey which was published in the newsletter of British Society of Echocardiography. It was published by Graham Leach. Some of you may know him. Now, in that survey, it showed that the average time for an echocardiography in the UK at that time was 24 minutes. And it hasn't changed much since then. You know what's the average time for echo in our lab? Guess? It's just 4 minutes. And this is just to show that we are more efficient than the British. Then again, echo, especially because of its workload, adds musculoskeletal stress on the operator, apart from mental stress. So these are many of the limitations. But how could AI help? It can help in automatization of tasks. Example, in determination of LV volume, mass, ejection fraction. It can save time. It can help in discovery of clinically important insights that human eyes may miss. And it can help in incorporation and analysis of echocardiographic and clinical data, which may help in diagnosis, determine prognosis, and help in decision making. Now, before we incorporate AI in our daily practice, we need to answer two questions. Is the AI-generated data useful? And is the AI-generated data accurate? So let us see what are the areas where AI could help echocardiography and whether they are accurate and useful. Firstly, about assessment of LV function, ejection fraction and longitudinal strain. Now the EchoNet RCT was designed to test whether AI-generated assessment of cardiac function was at least as good as that of a sonographer. So all these echoes were divided into two groups. In one arm, those who were actually assessed by the sonographer, and the other arm, which had AI assessment. And the results were blinded to an experienced cardiologist who didn't know which arm the report belonged. And it was found that the cardiologist agreed more often with the AI-generated data rather than the sonographer interpretation. And actually, statistically, it was shown that AI-generated data was superior to that of a sonographer. If you look at the FAST-EF multi-center study, it showed that AI-generated measures of LV function like EF and longitudinal strain were reproducible and could be done very rapidly. Coming to LV volume measurement, well, again, machine learning helped you to obtain the dynamic quantities of LV volumes more quickly and more accurately. And similar thing was true for LV mass measurement. Now, what about assessment of wall motion abnormalities? Now, it showed that the AI could prove improved detection of regional wall motion abnormalities, which was better than the human eye could perform. And another study showed that for detection of wall motion abnormality, AI has a sensitivity, specificity, and accuracy of 96%. And if you incorporate AI in its stress echo, then you can better categorize a group of patients who are at a low risk of imminent cardiac event. What about assessment of LV diastolic function? Now, in patients with suspected elevated LV EDP, AI was able to identify correctly about 80% of patients with pulmonary capillary wedge pressure more than 18, even from a 2D cardiac ultrasound image. And it was also seen that from a single apical 4-chamber transthoracic echocardiographic video clip, AI is able to discriminate patients very well, those with heart failure with preserved ejection fraction and those without heart failure with preserved ejection fraction. And if you compare the conventional scores that are used to diagnose patients with heart failure with preserved ejection fraction, AI did better in the sense that they are able to narrow down those those patients who would otherwise be non-diagnostic with the heart failure scores. Now, coming to assessment of valve disease. Now, we have learned about mitral valve regurgitation, MR, for example, but how many of you do you really get time in a busy lab to do all these things? Now, most labs, they don't. Forget about probably a few labs which are really good and doing it all the time, but most labs, they do not. They do not have the time, and probably they may not be that trained as well. So this comes to say, for example, measurement of PISA. It's time consuming. How many do it manually? But with AI, you can generate all the data in few seconds. So it's really helpful. Not only that, look at the valve morphology. There are other things that you probably may need. What about the mitral valve area? What about the coaptation length, coaptation depth that we talked about? All these things can be provided with AI. And similarly, AI can, in patients who are going for TAVI, AI can give us a measure of the aortic annulus, the size of the aortic root, and may help us to choose the TAVR prosthetic size. Now, coming to RV volume and function, yes, AI can also give an accurate quantification of RV volume and function. It may also help in differentiating among disease entities, such as to differentiate from constrictive pericarditis and restrictive cardiomyopathy, to differentiate hypertrophic cardiomyopathy from athlete heart, and also in patients with left ventricular hypertrophy, it can help to suggest the diagnosis, whether it's hypertrophic cardiomyopathy, amyloid, or maybe hypertension, which has caused the left ventricular hypertrophy. So far as intracardiac mass is concerned, AI uses image texture analysis to differentiate between cardiac tumors and cardiac thrombi. And in patients with cardiac tumors, they also suggest the differential diagnosis. Now, image acquisition, we know it's very important. And how does AI help? It may help the novices by teaching them how to do a good echocardiography and can get good pictures. And this is the way they can do it. They can actually prompt the sonographer regarding the use of the probe, the angle that the probe has to be moved. And also, if there's a good images obtained, they would probably capture it spontaneously. Now, it also leads to a change in workflow. And how is it done? Like, as you know, what we do now is the sonographer actually acquires the images, and then the interpreter, which is usually a cardiologist, would go through this non-consecutive images, that's 2D, Doppler, and then come to a conclusion or a diagnosis. With AI, you can actually group the relevant images together. For example, if there is a LV valve motion assessment query, that would display all the cine images of the LV serially, and it becomes so easy to actually make a diagnosis. Similarly, a query for aortic valve stenosis would display the 2D and the 3D or the LVOT images, the Doppler images all together, helping you to come to the diagnosis. Now, prognostication, yes, it's been seen like AI can help prognostication by predicting all-cause mortality by combining echocardiographic data with the medical information. Now, despite all its good points, there are certain limitations and challenges that we have today. Now, deep learning uses a black box model. And that is something which is very poorly understood even by the experts. So naturally, there is some hesitancy in its uptake by physicians. Next, there is large amount of well-annotated echocardiographic images that's necessary to train the machine. But we may not have all this data. Now again, when we train these machines with this data, these are mostly real-world data, and they have to be labeled. And then there may be a potential bias in the labeling process. Still now, there is paucity of studies with robust clinical outcomes. And then the suboptimal image quality during acquisition can also be a problem for AI to interfere and interpret. Presence of arrhythmias could be a challenge. Another thing we have to keep in mind is there may be racial differences in the physiology and anatomy of the heart. So an AI model which has been validated in a particular race may not be applicable to another. So this is something, so we actually need AI data for different geographical locations or different race. Of course, there are legal and ethical issues. If something goes wrong, who is to be blamed? AI or you? Who takes the responsibility? And the ethical issues, because we are dealing with a large amount of data, which are, what if there is a security breach and there is leakage of this data? So these things have to be sorted in future. So in conclusion, and I'm much before time, AI could help to train echocardiographers, improve image acquisition, and analyze and interpret scans, change the workflow pattern in the echo lab. It may help to improve diagnostics by measuring LV and RV function, LV mass, quantified chamber, help in assessment of diastolic function and valvular abnormalities, and help in differentiating disease entities. Deep learning could improve prognostication. AI-derived data is generally reliable and reproducible. AI could save time, improve productivity and workflow, and de-stress the operator. AI is coming in a big way and is here to stay, whether you like it or not. But the good news is it's unlikely to replace the physicians, but will complement them. So what lies in the future? I never think of the future. It comes soon enough, said Albert Einstein. And I can't agree more with him, because only this month there was a report that a robot committed suicide in Korea because of excessive workload. He jumped from the stair and some unusual behaviors were witnessed before he did so. So maybe in future, we should start thinking not about how to distress our sonographers, but perhaps how to distress our echocardiography machines. Thank you.